going to be talking about optokinetic chat stimulation, which is a novel neurorehabilitation intervention. Over the years, we have been looking at what is the black box of neurorehabilitation, what exactly is the active content of neurorehabilitation, and this has been a research question for which we haven't had an answer as yet. We, I think, at the moment concentrating on intensity. Is it best to do it in the acute phases? Is it best to do it in the chronic phases? So I have developed optokinetic chat stimulation as a novel intervention over the last 7 years. And that's what the optokinetic chat looks like. So it's a series of the colors of the spectrum. And as you can see, they are bundled with just a few gaps in between to allow for corrective saccades, to allow it to be acceptable to patients. Otherwise, for the duration of the 9 minutes that it needs to be done, if you don't give those chance for those corrective saccades, patients don't tend to tolerate it very well. It's a very simple to use intervention because all you do is place it 15 to 20 centimeters in front of a patient, either as an A4 chart or on an iPad. And the advantage is you can use it when patients are still in bed, when they are not yet mobile enough to be set out. So it's applicable whether it's a very dense stroke, a very dense traumatic brain injury, a very dense, say, post-critical care neuropathy. So you can start applying it right from when patients are lying in bed, which is a big advantage. You don't have to wait until patients are more stable to start their rehabilitation. And all you do is you move the chart from side to side for 3 minutes, up and down for 3 minutes, forwards and backwards for 3 minutes, to give you a total of 9 minutes. So how did this begin? What the lesson I learned from this is use other people's research, apply it in clinics as soon as possible, rather than trying to start all anew, reinventing the wheel. So at that time, there was a problem of trying to rehabilitate patients with neglect. We know they've got the worst outcomes in terms of their functional abilities. And then we knew that optokinetic stimulation was very useful in resolving neglect, and a few trials had been done by Kekoff and others which showed that you could resolve visual neglect in stroke patients. So I started applying that in clinical practice. And what I noticed then was, as I was moving the chart, the direction in which you moved the chart, the patients responded by moving their limbs in the same direction as the chart. So if you moved the chart laterally from side to side, the patients moved their arms from side to side. If you moved the chart up and down, the patients would also start moving their upper limbs up and down. And that demonstrated an immediate effect on the automatic motor system. So having observed all patients with visual neglect responding like that, I established, oh, there is a link here between the optokinetic stimulation and the motor system. And then going in to review the literature, researchers had also proved that link as well. So I started deliberately using the optokinetic chat stimulation, not just for neglect, but also to improve motor recovery. And the first complex patient I treated was a 78-year-old hemorrhagic stroke, severe neglect, pushing, which meant that they had no sitting balance, and with complete left hemiplegia. In terms of rehabilitation potential, it looked very bleak. We were thinking this patient is headed for a nursing home. But by 8 weeks, the neglect was gone, the pushing was gone, and the limbs had fully recovered from 0 out of 5 to 4 out of 5. And that was successful. The patient is still living at home. And that's 8 years. So that's over 8 years, and this patient is still living at home. Then after a few years, I decided I've treated enough of these complex patients. Let me look back and see who really benefits in terms of dense strokes. And my observational study indicated that no matter how disabled, how impaired stroke patients are, as long as the lesion, whether it's hemorrhagic or ischemic, is in the parietal lobe, if you use optokinetic chart stimulation, they still recovered movements and function after 8 weeks. Subcortical basal ganglia still recovered movements and function after 8 weeks. Parietal frontal recovered movements and function. Parietal occipital was one exclusion, which is parietal temporal. If it's parietal temporal, then you just recover function. It's compensatory. It's no longer a recovery. And after a while, I thought, yes, we have enough patients. We should be able to look back and compare retrospectively those treated by convention and those treated by optokinetic chart stimulation. There was only one disadvantage in that conventional sort of neurophysiotherapists tend not to record the muscle strength. They just call it activity limitation. So at the point of sort of intervention from the control group, there was no guarantee that patients had already spontaneously recovered, because we're then having to use what the physicians had entered in as the initial sort of pre-treatment muscle strength. But however, even with that limitation, we're able to show that 3 years later in the community, there was statistically significant improvement in upper limb recovery with optokinetic chart stimulation with PA less than 0.05. There was also, and this is really something that excites me, statistically significant prevention of spasticity, because we know upper limb spasticity in dense strokes is a very, very prevalent problem. We know a third of stroke patients who start with 0 out of 5 in their affected upper limb end up with spasticity. So being able to prevent that has a huge saving in terms of self-care, in terms of use of spasticity drugs as well. And there was a better trend towards recovery of lower limbs, which I think if the limitation of not having been able to guarantee the starting level of impairment, if it had been removed and it was under trial conditions, it's likely that we would have achieved statistical significance. I have done a pilot study to try and see if controlling at the point of intervention helps. And initial results. So the first phase of treatment, looking at the 8-week phase, which the case series had indicated would be the optimal time for recovery, and then carrying on follow-up treatment in the community for another 12 weeks. and then having a follow-up period of 3 months, which means we were then, the last outcome was 6 months from the point of randomization. And as we can see, the control group in terms of upper limb, lower limb, remains at 0 throughout the 6 months. The optokinetic charge stimulation for the lower limb gets to full recovery, 20 out of 20 by 8 weeks, and stays there up to 6 months. For the upper limb, rapid recovery up to the 8th week, then starts plateauing and gradual increments to 18 out of 20, and then by the follow-up period, back to full recovery, 20 out of 20, 6 months from point of randomization. Same for function. The control group, only 1 out of 20 over the 8 weeks. Then week 14, follow-up in the community. And that function reverts back to 0 by the end of 6 months. The experimental group with optokinetic charge stimulation, 15 out of 20 after 8 weeks, 17 out of 20 after the follow-up period in the community, then 18 out of 20 after 6 months. And this is mainly because the patient lived in a bungalow, which is flat, so they didn't need to do stairs, so they were not assessed on stairs, which if they had been assessed on stairs, they probably would have scored 20 out of 20. Now looking at spasticity, optokinetic charge stimulation group, 0 throughout, so no spasticity of the affected hand. Control group started with no spasticity, but as we know, over time, it started creeping up, and by 6 months, the spasticity had started registering. And I followed up the patient after the study, because the family had asked me to intervene after the study had finished. And by then, the upper limb had really become very spastic. Even the lower limb had become spastic. So prevention of recovery, as we know, aids in prevention of spasticity. Now, at the same time, although my focus was on stroke, as people became aware throughout the hospital of the benefits, I began to be called to deal with neuropathies, especially after admission to intensive therapy units. And people who stayed longer in ICU ended up developing weakness of all 4 limbs, becoming very weak, bed-bound, and generally being called after 2 months at least of people not making any progress, being bed-bound. And as soon as we started optokinetics, full recovery of muscle strength, recovery of function, and the main key thing is either this axonal degeneration or also degeneration of the myosin heavy chain. And a case I was treating only in the last sort of month, it was so interesting to see that the loss, especially one of the key muscles we look at is the ankle dorsiflexors, and to see the wasting of those muscles, and then as you do optokinetics, just seeing that gap filling up without exercises. So it shows just how much change in the chemical reactions in the muscles occurs once you restore the innervation. So this is how, because these people, when they go for their operations, they're coming in with full function, Bathel index 100 out of 100, muscle strength 5 out of 5, and then over weeks they start losing that and they come back to 0, and then they go on with conventional rehabilitation and stay at 0. Then when you start optokinetic chat stimulation, you can see they start picking up again to go back to their premorbid functional levels. And this also happened that, again, as people became more aware of the benefits, got called to deal with traumatic brain injuries, and the same results that we had been seeing in stroke patients, we were seeing traumatic brain injuries, and this complete loss of power, 0 out of 5, bed-bound, no sitting balance, start optokinetics by 8 weeks, full recovery of muscle power, 5 out of 5, function, independent mobility, and in the past 6 weeks, I had one peculiar case where the patient was minimally conscious. Normally, we have used optokinetic chat stimulation, people can open their eyes, but this patient is unconscious, cannot open eyes, and we did something we hadn't done before. So I instructed the physio I was working with to keep the eyes of the unconscious patient open and started stimulating them with the eyes open while lying in bed. And this patient had been in hospital for 3 months. Within days of doing that, the patient was sitting out in a chair. And the patient is now walking. And yeah, that was really remarkable. So we intend to publish that case study because this is the first time we had done this. And yeah, it looked like a miracle. So I think it's giving us a window into minimally conscious patients as well, which would be a new application. So optokinetic chat stimulation still needs rigorous RCTs to confirm its efficacy, and I'm in the process of making major grant applications across all stroke, traumatic brain injuries, critical care, neuropathies, and GBS. Although I've treated GBS, I've only treated a few cases, and I didn't feel they were giving me enough robust evidence. But I'm thinking, now that we've seen in critical care neuropathies that it works, maybe do multi-center trials for GBS, then we can widen the net to get more patients. So a lot of people would say, why concentrate on the dense strokes, the one with complete hemiplegia? Because they are fewer in terms of prevalence. Most stroke patients will have hemiparesis. But if you can reverse complete hemiplegia, it means you will then take less time treating hemiparesis. And this is something I've observed in clinic, that where we would have spent months then following patients into the community, if I use optokinetic stimulation with hemiparesis, it just takes days and the full recovery. And when you say, do you need to follow up in the community? They say, no, I'm fine now. So there would be a lot of commercial sense in you. So one of the studies I'm planning is a study where we're just comparing the speed of recovery for those with hemiparesis, just to look at economic evaluation. The greatest potential is in upper limbs, because upper limb recovery still remains a major problem in neurorehabilitation. And if we can find a solution to that, to make a lot of economics savings. We know that autonomy depends on upper limb function, because people can dress themselves, they can wash themselves if they recover the dominant upper limb's function. So there is a long way to go, but I think we've taken the steps to try and provide the evidence for guidelines to be changed. Thank you for listening.
Okay. Any questions? Yeah, okay, I have a question. I think like exciting, like discovery, like patient lie down there, later on will be like stand up and sit down chair. So my question is, this OKCS treatment have any difference for TBI patient, like a traumatic brain injury patient, or ischemia, stroke patient, or ICH or ICH? Any difference? It's like specific, one better than others?
At the moment, the recovery times are similar. So I'm saying the critical 8-week period. And this, I think, has been borne by studies by Professor Crocker. And what he's also done is in both animal and human studies, found that that 8-week window is the best window for recovery. So what other researchers have been doing in the USA is also bearing the same evidence in terms of the critical window for recovery. So the 8 weeks, it's uniform, whether it's polyneuropathy, traumatic brain injury, subdural hemorrhages. The only patients I haven't studied it on is subarachnoid hemorrhages. So with SAH, I don't know at the moment, but in terms of subdurals, polyneuropathies, and ischemic and hemorrhagic stroke, it's the same window period of recovery.
So you mean the window is very important, what time treat for the patient?
Yeah, very, very important. Okay. And it's interesting though, I think when you look at the strokes I said would recover, for those I mentioned, even when I follow them up, you don't get full recovery because muscles have changed. So sometimes you will get the movements, but they are no longer the proper movements because muscles have shortened. Tendons have already changed as well. So I find that when you try and do it after 3 months, you're resting against changes in the muscles themselves.
Okay, thank you. And here's certificate.
Oh, there's one more question.
Sorry, yeah, go ahead.
What about spasticity with things like Parkinson's disease? Is there a possibility for that?
There is a possibility, and unfortunately when I treated a very complex patient, Parkinson, I wasn't very research-minded by then. But I was called to treat a Parkinson's disease patient, very advanced, a medical doctor by profession. And the problem was, because the spasticity had got so bad that the legs had crossed over in flexion and adduction, personal care was very difficult. So when I was called to see him, I started optokinetic chart stimulation. Within 2 days, the legs uncrossed. 3rd day, enough to sit over the edge of the bed. And then he got moved to a nursing home.
Miracle. Exciting.
So,
exciting.
and I think the key is the anti-gravity extensor system, because then it reciprocally inhibits the flexors, and that's where the key is.
More questions? Yeah. Okay. So now I give you a certificate. Thanks for the nice presentation.
Thank you.